So I'm going to deal today with, my presentation will deal with what to expect after the diagnosis and successful treatment of melanoma from the perspective of ongoing dermatology care. So there are estimated 14 million cancer survivors in the U.S. today, over 1 million of which are malignant melanoma survivors. The focus after treatment of any cancer is on recovery, surveillance for recurrence of cancer and metastasis, and overall maintenance of general health. In particular, changes that we need to address in the post-operative period may include everything from emotional effects of having a diagnosis of cancer, to changes in activity level or appetite, to continued changes at the surgical site, wound care, pain, numbness, and so forth. Just want to mention survivorship care plan a little. This is analogous to sort of a treatment plan when one is diagnosed with cancer. After treatment of cancer, a survivorship care plan will be discussed with the patient. It should include a summary of all the treatment that has been received. It should also include a plan for follow-ups with certain healthcare providers and scheduled imaging tests such as CT scans or blood work. Probably most importantly, should include signs and symptoms that a patient would want to make their physician aware of if they should present. In terms of melanoma, there's two basic principles for ongoing surveillance. One is an increased number of visits early in the course of disease and increased frequency right after treatment. That's because that's the most likely time for recurrence. And unlike with some other cancers, for melanoma, follow-up would be continued for life because there is a high rate of developing other types of melanomas or non-melanoma skin cancers. So again, the rationale for continued follow-up with dermatology: surveillance for the recurrence of melanoma, development of new melanomas. About 10% of patients who have a melanoma will go on to develop multiple melanomas throughout their lifetime. The rate is about 0.5% a year for the first 5 years, and then a lower rate afterwards. The incidence of multiple melanomas in patients is particularly high in two age groups: the very young at the time of the first diagnosis, 15 to 30 years of age, and the elderly, 65 to 79 years of age. In terms of recurrence, the most common location would be the draining regional lymph nodes of the site of the original cancer. In the vicinity of the original cancer would occur 30% of the time, and 24% of the time it will occur at distant sites. A study in the Journal American College of Surgeons in July 2013 found that the recurrence of malignant melanoma 10 years after the initial treatment is much more common than previously thought. The researchers estimated a over 6% recurrence rate for patients who were 10 years post-treatment. Some patients in this study had a recurrence 18 and 19 years out from their original cancer treatment. These patients that had late recurrences typically were younger at the time of the initial diagnosis, and these patients also tended to live longer after recurrence compared to patients who had recurrence the first 3 years after their treatment. That would suggest that these cancers were less aggressive or more indolent in nature. So, in terms of monitoring for recurrent disease and second cancers, checkups with a dermatologist will include a very intense skin examination of the entire skin surface and examination of the lymph nodes. For some patients with high risk of recurrence, blood tests or imaging scans such as CAT scans or PET scans will be scheduled, although that's usually not the case with most melanoma survivors. A recent study in the Journal of the American Academy of Dermatology did follow patients with mostly stage 2 disease and some patients with stage 3 disease with whole body CT scans and brain MRIs every 6 months for 5 years following their treatment. Not surprisingly, this intensive regimen of imaging did aid in the detection of metastatic disease. However, there was a very high rate of false positives. That would be findings on a CAT scan or MRI that upon further testing does not reveal cancer. These patients underwent unnecessary biopsies and other tests. In addition, surprisingly, at least in these patients, there was little statistically significant difference in long-term outcomes between patients who received intensive imaging and those who were just followed every 6 months without the imaging. The researchers concluded, therefore, that the greatest value of imaging for most patients after treatment of melanoma is in the setting of patients presenting with concerning signs or symptoms to their physicians, and secondly, to determine the extent of disease once a recurrence has been identified. The National Cancer Network guidelines suggest at least an annual follow-up for life with intervals ranging from 3 to 6 months for the first 3 years after treatment, and annually. I think every institution probably has a different schedule for their melanoma patients. At Fox Chase Cancer Center, our dermatologists typically see patients every 6 months for the first 2 years and then annually thereafter. That would be the typical, but many of our patients aren't typical. So we have probably 50% of patients are being seen more frequently, longer. One of the things is just geographic. Maybe they have a long commute. In those cases, we do work with local dermatologists close to the patient's home, where we'll have them see the patient every 4 or 6 months, and then they can see us every year or every 18 months. More commonly, I would say that patients have high risks for recurrence, and we will see them more frequently. Some of those risks would be a very strong positive family history for melanoma. Just having a large number of moles, or what we call Nevi, puts a patient at higher risk for future melanoma. A lot of our patients have numerous non-melanoma skin cancers, such as basal cell or squamous cell cancers, and so we're following them frequently for those. And finally, we do have patients who have known genetic mutations to tumor suppressor genes, and they need to be followed usually every 3 to 6 months for life. Some other factors that would determine increased risk, some of this was already reviewed. And the most important here is the thickness or the invasiveness of the primary melanoma. That's by far the biggest factor. Other things about the primary melanoma, including ulceration at the time of diagnosis, presence of satellite metastases. These are small foci of tumor that have broken off from the main body of the tumor but are in close vicinity. The presence of an increased mitotic rate, that's a finding on pathology. It's in regards to how the cells look under a microscope. Those are all place the patient at a higher risk for recurrence. Older patients are also at a higher risk for recurrence. And finally, anybody with a compromised immune system also need to be checked more frequently. In my clinic, there are a number of patients who have organ transplants that are immunosuppressive regimens, and also some patients who have second malignancies, such as a chronic leukemia or lymphoma, whose immune systems are not functioning the way they should, and those patients typically see me every 3 months for life. So I have to mention a little bit about atypical nevi, which is the same thing as moles. So we mentioned that a lot of moles itself on a patient's skin will increase the risk for melanoma. We know that a substantial number of melanoma cancers do arise from a pre-existing mole. A study in 2007, a large study of 8,600 patients that appeared in the British Journal of Dermatology. These patients were followed at a pigmented lesion clinic, and over time, about 377 patients were diagnosed with melanoma. The researchers were able to identify 42% of those melanomas which arose from a previous mole. 34% arose de novo without a preceding lesion, and 24% the researchers were uncertain of the origin. So a majority, or at least a plurality, of melanomas do arise from a pre-existing mole. This is even worse for atypical moles. Now, an atypical mole is not the same thing as a dysplastic mole. An atypical mole is a clinical diagnosis. A physician is looking at the skin surface, sees a mole that has atypical features. That would be an atypical mole. A dysplastic mole is, again, a finding on pathology. So that's how the cells look under the microscope. However, for our purposes, both atypical nevi and a dysplastic nevi increase the rate of development of melanoma. Those patients need to be checked frequently. To date, atypical moles or dysplastic moles are the most important precursor lesion for an increased melanoma risk. How much of an increased risk? Well, studies have estimated that a malignant melanoma risk was increased as high as 57-fold for patients who have atypical nevi in the absence of a personal or family history of melanoma. If you have a personal or family history of melanoma, that increased risk jumps to 400-fold increase. In addition, these are very common lesions, so upwards of 1 in 5 adults have atypical nevi. So our patients who have atypical nevi, during the examination, we'll do something which is sometimes referred to as mole mapping. So we'll focus on documenting the location, the size, the color, the number of these moles. Now, this is effective for patients who have a small number of dysplastic nevi. Let's say you have 6 or 10 or 12. Unfortunately, some patients do inherit a trait where they produce large numbers of atypical moles, 25, 50, or even 100. And obviously, in those cases, it's not feasible to map every one of these moles on an examination. In addition, it's not feasible to biopsy or remove every one of these moles. In fact, all of these moles, in a lot of patients, will show some dysplastic changes. So in this case, what I found myself is that the best aid for following these patients is total body photography. There is a company that we work with at Fox Chase Cancer Center, Dermatologic Skin Imaging, that has multiple centers in the area. They do have a website. They employ medical photographers who will photograph a patient's entire skin surface. You will then take a disc home with all the images, as well as a binder which has all of the photographs along the different body segments. You bring the binder with you at every visit. The dermatologist goes through the binder segment by segment and compares the moles to the patient's skin surface at the time of the visit. Any moles that show a change, either in size, color, or shape, those moles are the ones that will be biopsied or removed. So this saves patients a lot of unnecessary procedures and also a lot of anxiety. This is usually not a covered service, so payers are not paying for total body photography. The cost, I think, is about $400 to $500 for total body photography. However, most patients who have a history of melanoma do not require total body photography. I would say probably 5% of my patients I'm sending for photography because they have a large number of moles that make it difficult to monitor over time. In addition, the cost is a one-time cost. You do the photography one time, and you bring your binder with you every visit. There's no real reason to do multiple sessions of photography after that. A really important point is that anybody with a history of melanoma should be recommended to do a monthly self-examination of their skin. The technique for doing so should be reviewed with a patient. Studies have shown that this has greatly benefits in early diagnosis of melanoma, so finding the next melanoma at a thinner depth. So less invasive equals better chance for cure. And that's the goal here, is to find these next melanomas very early. I'll go over a little bit of the technique, which is the ABCDE strategy, which probably a lot of you already know about, but I'll go over it relatively quickly. A stands for asymmetry. So if you drew an imaginary line down a mole, one half of the mole should be the mirror image of the other half. If that's not the case, that's asymmetric, and that's an atypical feature. B stands for border irregularity. A mole's border should be nice and clear-cut, and nice in a clear-cut manner, not have pigment that spills over or have notched borders. C is color. Moles should be all one color. D is diameter. We don't worry too much about moles that are less than 6 millimeters in size. If a mole transforms into a malignant melanoma, typically it's going to grow in size. So as a mole gets larger, that's when we are more concerned. Most important is E, which stands for evolving over time, which is just change. That's by far the most important feature. When a patient comes to see me as a follow-up, I typically simply ask, have you seen any moles that are changing? I don't really care how they've changed if the patient has a history of melanoma. If the patient tells me this mole has changed in any fashion, it's just become more noticeable to the patient, then I think that warrants removal of that mole or at least a biopsy. This is a form that can be found and printed out from the American Academy of Dermatology website, which is aad.org. This website has a lot of information for melanoma survivors, and I encourage you to take a look at it. This form, which can be printed out, will go over how to perform a self-examination. It also has a body template where you can mark where your moles are located on the body. And at the bottom there's a chart. So you would put down the size of each of the moles, the color, the shape, and so forth. And each month when you do your self-examination, you would use this to just make sure there hasn't been any changes. And if there are, you would bring that to the dermatologist's attention at your next visit. In terms of prevention, so the number one preventive measure for all types of skin cancer, melanoma, basal cell skin cancers, squamous cell cancers, is to avoid excessive exposure to sunlight or UV radiation. In my patients who have had a melanoma, I tell them to absolutely avoid exposure midday, 11 a.m. to 3 p.m. Absolutely no indoor tanning. Indoor tanning, studies have shown after as little as 6 to 8 indoor tanning sessions, your melanoma risk rises dramatically. Obviously, we would tell patients to wear protective clothing and sunscreen. In terms of sunscreen, we recommend an SPF of at least 30. I tell most of my patients to use either a 30 or 45 sunscreen. Apply the sunscreen 30 minutes before exposure. That's important. All my patients, I instruct to use a facial moisturizer that has an SPF 15, should be broad spectrum, and to use that on the face, the back of the neck, every day throughout the year. So when choosing a sunscreen, it's important to choose one that has both protection against UVA and UVB rays. That should be labeled broad spectrum on the bottle. So SPF, or the sun protection factor, was developed not to measure a sunscreen's ability to prevent skin cancer. It was developed to measure a sunscreen's ability to stop a sunburn reaction. It has really nothing to do with protection against skin cancers. Only one area of the ultraviolet spectrum causes sunburn reaction. That's called UVB. These are the shorter wavelength rays. They cause inflammation and a sunburn reaction. So SPF is only measuring protection against UVB. UVA, is a part of the ultraviolet spectrum, has a longer wavelength, and these actually penetrate deeper into the skin. They also cause skin cancer because they damage DNA over time, but they will not cause a sunburn reaction. So your SPF only tells you so much. You need to find one that's broad spectrum. How good does it block UVA? Well, that's another question. Just because something says it is broad spectrum doesn't mean that it's doing a very good job of blocking UVA. That's why we typically recommend 2 ingredients, titanium dioxide or zinc oxide. Both of these ingredients work differently than other sunscreen agents. Other sunscreen agents are chemical blocks. That means that they absorb a portion of the ultraviolet spectrum, but not all ultraviolet rays. That means that the sunscreen has to be formulated with multiple different ingredients to cover as much of the ultraviolet spectrum as possible. Titanium dioxide and zinc oxide work differently. They are physical blocks, so they're just blocking sunlight from coming through the skin. So when somebody who has a history of melanoma, we definitely want patients to find products that have titanium dioxide or zinc oxide. Patients sometimes don't like this because it does leave kind of a whitish residue on the skin. I think that some of the newer agents, especially with Neutrogena, are more cosmetically acceptable, however. So I think that this is definitely the way to go. In terms of application of sunscreen, you want to apply liberally and reapply every 2 hours, and more so if you're swimming or sweating. How much should you apply? Well, a typical adult or a medium-sized adult, which is 150 pounds, needs a full shot glass of sunscreen lotion for application. If you're a larger individual, you're going to need more than that. The last thing I would say is that first-degree relatives of patients who have melanoma all should be screened annually for skin cancer. That's shown to be a benefit. By conclusion, I have 3 studies that have been done over the last few decades. I could have included probably a dozen or 20 studies that all show the same thing. The take-home point is that, honestly, we cannot prevent new skin cancers, whether non-melanoma or melanomas, from developing in a patient who's prone to getting skin cancers. Like the earlier slide showed, about 10% of patients will develop multiple melanomas in their lifetime. Our goal instead is to detect them when they're early, when they're thinner lesions, and when the outcome and chance for survival is much greater. These studies and other studies like this show that routine follow-up after initial melanoma diagnosis in conjunction with good patient education, which would include the monthly self-examination of the skin, is associated with detection of second melanomas, which were significantly thinner than the initial cancer, and therefore yielded better long-term survival and outcomes. Thank you.